And we are live. Good morning, everyone, from the third appointment of the live talk promoted by the International Coronary Congress. And we are here today to discuss the implication of the ischemia trial in the practice of coronary artery bypass grafting. We have a worldwide faculty that today join us for this 1 hour conversation. The major mojo, the major inspiration of these talks that are promoted by International Coronary Congress are aimed to increase the overall knowledge among cardiac surgeon, cardiovascular research, and cardiologists about major topic in cardiovascular surgery literature. We truly believe that a thorough understanding of the literature in regards of the management of coronary artery disease is vital to the effective leadership of cardiovascular surgeons within the heart team. And with this aim, International Coronary Congress does not want to be only a meeting, one appointment once per year, but rather wants to make sure that culture is widespread throughout the year with this monthly appointment. Today, together with me, there will be an incredible team that will discuss. We'll start with Dr. Leslie Sean, professor of Icahn School of Medicine at Mount Sinai in New York City, leading cardiovascular outcome researcher and one of the authors of ISCHEMIA. We have Michael Farku, who just joined us, professor and vice chairman of the Department of Medicine at University of Toronto, and Peter Munich chair in the multinational clinical trial. We have Dr. Marc Ruel, professor and chairman in the Division of Cardiac Surgery at University of Ottawa Heart Institute. We have Mario Gaudino from Weill Cornell Department of Cardiovascular Surgery, and Dr. David Taggart from Professor of Cardiovascular Surgery at Oxford University, John Pascas, Chairman of Department of Cardiac Surgery at Mount Sinai Morningside in New York City, and the very last minute and incredible guest, Dr. Blaise Carabello, Professor and Chief Division of Cardiologist at ECU. So we are here to discuss ischemia trial, this incredible paper that has been published on New England Journal of Medicine in 2020. And I will ask Leslie to start introducing what is ischemia trial, where it comes from, why we felt the need of ischemia trial in the history of the trials on cardiovascular research. Please, Leslie.
Sure. Thanks, Gianluca. I think, as all of you know, that ischemia trial was one of several large stable ischemic heart disease trials, notably Courage and Berry 2D were prior trials in about 2,000 patients, which were negative trials and published comparison of a revascularization or invasive strategy as compared to optimal medical therapy, with Berry 2D being in type 2 diabetics, but both negative trials. So in both of those trials were criticized for enrolling lower risk patients, particularly patients that didn't have a lot of ischemia. So the thought was, the premise underlying the ischemia trial was, if we got a consistently higher amount of ischemia, could we then elevate the findings from the acute invasive trials, which show a consistent pattern in the acute setting with ACS and myocardial infarction of a demonstrable benefit with invasive strategies of care. So that was what we embarked on about 10 years ago. And up until last year, we continued to enroll, and it was a very large trial of nearly 5,200 patients. Patients were randomized to optimal medical therapy versus an invasive strategy. There are key eligibility criteria. Moderate to severe ischemia. Challenge was it was site determined. Had to have an ejection fraction of 35% or more. It excluded left main stenosis. All of these are critically important to frame the results. No recent ACS, And so these are the most prominent findings, eligibility criteria. So patients were followed for about 3 years. The endpoint was cardiovascular death, myocardial infarction, resuscitated cardiac arrest, hospitalization for unstable angina or heart failure. And as all of you know, there was no significant difference in the primary outcome at the end of about 3 years of follow-up, as you can see here on the slide. Now, importantly, the overall differences are important, but there are some significant points that we need to comment upon and discuss, and all of you will have more insight into some of these areas than I do. There was an potential early difference in outcome that did not favor an invasive strategy, perhaps even early harm, which was totally targeted not to cardiovascular death, but to perioperative myocardial infarction. But also importantly, towards the end of follow-up, you see a separation of the curves, which is suggesting a favoring of invasive therapy, and there will be a continued follow-up of these patients that is ongoing as we speak. Important subgroup of component endpoints, which show interesting results. It's about a 50% reduction in unstable angina with invasive therapy, as well as a 33% reduction in spontaneous myocardial infarction, which is hopefully what you're seeing towards the end of the trial. So these are important findings that I think we can discuss. One additional finding, which is really noteworthy, is that of the consistent, which you see consistently across the stable ischemic heart disease trials, you see a benefit in terms of angina control with invasive therapy. Now, importantly, all patients had ischemia or were supposed to have ischemia as they entered the trial on stress testing, and about 2/3 of patients had some ischemia, had some angina at baseline. And what we saw when you compared angina control between the two arms of the trial is that you saw a prompt at about 3 months, a prompt and a durable improvement in angina control with invasive therapy. There was not the benefit for patients that were asymptomatic at the time of baseline. Of course, that makes sense. If you don't have symptoms, you're not going to have improvement in symptoms. So I think those are the major benefits that you can see in terms of the ischemia trial. Of course, I think for a lot of us, it was quite disappointing. A lot of planning, as all of you are very big trialists and know that these things can be a challenge. But the results, I think, are yet intriguing and hold a lot of possibilities for the future, particularly for longer-term follow-up. So I think that's kind of a 20-second wrap-up of the trial, and we can start our discussion about all of your interpretation. It would be interesting.
Leslie, thank you so much. I gave you one of the most hard topic to do, that was presenting ischemia in less than 6 minutes with basically one slide. I think that is pretty impressive if we think what ischemia has been, the difficulties that all of you authors have put in this, and the efforts that you guys have put in this trial. And Mark Ruel, Mario Gaudino, Mike Farku has been asked by Journal of Thoracic Cardiovascular Surgery to write an editorial about the implication of the ischemia trial in cardiovascular surgery. And I think that the implication overall of the ischemia in the cardiovascular world has been incredible. And Mark, what do you think about the way in which ischemia trial has been perceived from the general public, and what is the message when you first read the paper? What did you thought? What were your taking-home message?
Well, thank you, Gianluca. And first, I want to say no one introduced you. You're a successful young surgeon who's shaking the field and doing minimal invasive cardiac surgery now in Lankenau in Philadelphia. So we're very glad for you to take the lead on moderating this and inviting key speakers to this session, excluding yours truly. I don't know why you invited me, but certainly Leslie's perspective was absolutely wonderful. And Leslie, I want to extend my kudos to you for providing a very thoughtful interpretation of ischemia, not a biased one. Not that the biased one is often seen, but certainly the perception of the trial around the community has been difficult to manage, right? And I'm sure you, as a leading author, realizes this, and I like the careful interpretation that you provided, because essentially ischemia casted a very wide net, right? It casted a wide net of early intervention in terms of an invasive therapy, of doing an angiogram, finding out, versus not doing that right away. And that net is extremely wide because, again, there's a few numbers that are tremendously important here. There's, as Leslie said, there's close to 5,200 patients. So about 25, just shy of 2,600 patients per group, invasive versus conservative. In the invasive group, which people tend to associate with the revascularization group, well, there are some very surprising numbers. 59% of patients had PCI, not 80%, 59%. 20% of patients had bypass surgery. And guess what? 21% of patients had nothing. That's in the invasive group. Okay, so you cannot say that this has invalidated the role of bypass surgery, which has been long established, and we're now, several of us in this call are trying to reestablish, because it's time for the world to know that when you pull these data, they are clearly in favor of bypass surgery. There was also, that group was not as benign as many like to think. There was actually multivessel CAD in 71% of patients in the invasive group. We don't know about the conservative group because they didn't have an angiogram. I mean, you can infer from CT, but not everyone had a CT. It was mostly to exclude left main disease. And there was triple vessel disease in 40% of patients. Further, there was also diabetes in about 42% of patients overall. So you can imagine there's quite an intersection of patients here who probably would have benefited from CABG, right? Diabetics, multivessel CABG, etc. Yet only 20% really received it in the invasive strategy. So even less in the overall trial. So I think, ischemia is a great trial, but it casted a very wide net. It casted the net of, it's a little bit, I use the example, let's go on Fifth Avenue in New York and find 65-year-old smokers and randomize them to undergoing a CT scan with invasive therapy for lung cancer versus leaving them alone. We'll probably find at 3 years that it makes no difference. That doesn't mean that surgery for lung cancer has no purpose. It doesn't mean that a CAT scan for lung cancer has no purpose. But the wider net that you cast, the less likely you are to have a specific beneficial effect for each of your individual interventions. So I want to be careful here that we don't interpret ischemia as something that invalidates CABG. There was previously in stable ischemic heart disease a lot of data supporting that revascularization with PCI probably has no impact. Courage, Berry2D, Orbita, others, right? I mean, so here, really the effect, potential beneficial effect of bypass has been extremely diluted. And people have to understand, back to Leslie's point, what the trial design was about. I'll stop here, but I think there's really a great summary from Leslie, and such an interesting trial. And again, kudos to her and all the investigators who led this tremendously important trial.
Michael Farcoux, tell us a little bit your opinion as you've been part of this editorial and you are a leading cardiovascular researcher as well, a cardiologist. What is your taking home message? What do you think about what Mark just shared with us?
I think Mark is spot on. Of course, I've worked with Mark for many years and with Mario, and I think our editorial was timely and appropriate. I want to make the point that I don't think it's inconsistent with the results of ischemia, as Mark points out. Ischemia is an interesting trial. It's well conducted. Leslie, a wonderful presentation and interpretation. Thank you so much. And I want to thank everyone for inviting me this morning. I think there are a couple of caveats I just want to point out. In the conservative arm, there was a CT scan, a CT angio performed. So we did define some of the anatomy. We know the patients who don't have significant obstructive disease, and we ruled out the patients with left main. And so the biggest problem with ischemia in the interpretation in the field is that if I have to undergo a CT angio and I'm on a clinical service, I'm not going to ask the radiologist, tell me if they have no disease or if they don't have left main. I'm going to look at that angiogram and I'm going to see that 90% LAD lesion. What am I going to do about it? Because in the real world, I can't tell someone, just tell me whether there's left main or no disease. So the real challenge of ischemia is how do we put it into practice? So I think that ischemia opened the door to one thing that's very important. This whole obsession in the cardiovascular community to screen for ischemia. That's what's brought into question in this trial, in my opinion. But if you look at the clinical trials that have been conducted in the past, they've been defined by the anatomy. So in the FREEDOM study, which is the pivotal study in diabetes and multivessel disease, and in all the trials that were included in Stuart Head's meta-analysis, which definitively showed a mortality benefit, at least for patients with diabetes and multivessel disease, irrefutable. In those cases, patients were eligible based on angiography and anatomy, not based on ischemia. So the real way what is brought into question is this whole issue of how we incorporate CT angio into our practice, in real world practice, and how do we test whether testing for ischemia is important, because everyone in the trial had ischemia. But what about the patients who had multivessel disease and didn't have demonstrable ischemia on some functional study? What do we know about that? So that's what it's really brought into question. So to me, in many ways, ischemia has opened the door to many new questions as opposed to answering questions.
That's a great point, Michael. Really, really well taken. And I think we are entering into this concept that is way more common nowadays. So with all of this attention that trials have on medias, on internet, it's very frequent that the major message of a trial get misled by just a title. That the abstract is taken and the final message that is delivered is very different from the intention of the researcher or the original clinical investigation. I want to involve John Pascas and Mike Carabello in this one, and they are together. They are winning the award today for best background in this live talk on a Saturday morning. I mean, and tell me that you are also drinking a cup of coffee, Dr. Pascas, and you are really like become my myth. But it is true in one way that, the first, all of the headlines of ischemia were medical therapy beats CABG and PCI. This was the headline the day after ischemia. How can we change the way in which we deliver messages? How can we make sure that people don't read abstract, but they are aware of what a trial is? Please.
So, my basic concept of the coronary arteries is that they're there to supply blood to the heart valves. If I were to take a broader view, I think it points to the importance of symptoms, as crude as they are, as low tech as they are. If a person is able to go up 3 flights of stairs and not have angina, that's a piece of information that goes beyond the objective quantification of ischemia. And so I think that the need to take everybody on a case-by-case basis, the trials are very important. It tells us a lot. But for someone who, I do worry about the 40% of the people in the trial who are diabetic, and in whom symptomatology may not tell you what you need to know. But I think otherwise symptoms are a crucial thing. And for patients whose symptoms are stable, that's a good prognosticator that they're doing okay. And then I would ask the panel, somehow you wind up with a positive test, you get an angiogram, and you've got a 99% proximal LAD. How many on the panel would just say, oh, well, okay, but my angina is stable, I'm not doing anything about it?
Yeah. And this is a great question. Dr. Taggart, tell us a little bit the answer of this question. You see an angiogram. How does ischemia change the way in which you practice? First of all, did you perceive that ischemia has changed the way in which you practice, or even just in terms of volume? Came out in a difficult times to predict volume because was COVID. So, but overall, do you think that there's been a changes in this sense? And what Dr. Carabello was just saying, like now you have findings. Do you look differently the angiogram now that you know that a conservative strategy, at least at 3 years, does bring the same type of outcomes than a more aggressive one?
So the short answer to that is no, it hasn't changed our practice at all. We run very rigorous multidisciplinary heart team meetings with non-interventional cardiologists, interventional cardiologists, and cardiac surgeons, and they're pretty rigorous reviews of patients. I would like to congratulate Dr. Shaw, Mark, Mike Farku, and Dr. Carabello for their superb comments. So it's difficult to add much to it, but I would make 2 cautions about ischemia. Whenever I look at a trial, there are 3 things I need to know. Who were the patients? What was the duration of follow-up? And did the patients receive optimal or guideline-directed medical therapy? And in one of the major strengths of ischemia is with regards to making sure patients did get optimal medical therapy, then yes. But I've seen this repeatedly over the years, whether it was Syntax, Freedom, Excel, that the longer you follow patients who have a CABG revascularization, you see this growing discrepancy, accelerating survival benefit in favor of bypass grafts. And what that's telling you is if you've got a patent mammary artery on your LAD, you're going to do very well over the long term. If you look at the fact that the mean age of these patients is mid-60s, then what we're really talking about when we talk about revascularization is what is the outcome for that patient over the next 20 years. So my view is I will bet any sum of money that by the time you get to 5 years, you'll begin to see a revascularization benefit in ischemia in patients who had active revascularization. The real disappointment of ischemia, as Mark Ruel alluded to, was that almost 2/3 of the patients getting revascularization got the wrong revascularization. They were given PCI in contradistinction to what the guidelines would have recommended. So that's my caveat about ischemia. But it is a great trial, and I'm not trying to say it's not providing us with additional important information. The overall major concern with it will be the perception by the community that it is widely being interpreted as a trial of revascularization versus no revascularization. All of us know that is wrong, but that is the perception.
I'd like to comment on that because here we are, a panel of cardiologists and cardiac surgeons. You see here, I happen to have my dear friend Blaise Carabello, a very famous cardiologist, enjoying the Labor Day weekend here with his family in mind. So our symposium this morning, and indeed my weekend here, embodies the heart team approach, a collaborative friendship and partnership between cardiologists and surgeons. And yet in the ischemia trial, we lumped together PCI and CABG and called them revascularization or invasive strategy. And that actually is not a good idea. And the reason is not because, PCI is evil and CABG is wonderful. That's not true. There are patients who should absolutely have PCI. My own father was one of them. And there are patients who should have coronary bypass surgery. But calling the two together one thing, one entity, revascularization, is a mistake because they work very differently. PCI, we must remember, expands a flow-limiting proximal lesion and maintains its patency with a stent. It doesn't protect against future myocardial infarction, especially not against myocardial infarction that is caused by non-flow limiting lesions that were not stented, but which may have vulnerable plaque and are prone to later thrombosis or rupture and occlusion causing myocardial infarction. Coronary bypass, on the other hand, delivers an alternate route for blood to reach the distal myocardium by a graft that goes beyond the flow-limiting lesions and beyond non-flow-limiting lesions in the proximal half or even 2/3 of the vessel, and typically protects against future myocardial infarction much more effective than PCI can, especially FFR-guided PCI, which really restricts PCI to flow-limiting lesions. And that's not, a disservice or a disrespect of the PCI technology, but rather just a simple fact that these two therapies, which are called invasive therapy and lumped into one category in the ischemia trial, actually benefit patients by very different mechanisms. And so one would expect different outcomes for patients. I'm going to just close by again emphasizing what Mark Ruel first brought up. And when we have someone of the stature of Michael Farku on the panel, to ignore the impact of diabetes and on multivessel disease outcomes when we have the first author of the Freedom trial on the panel is kind of insane. We know that PCI in multivessel diabetic patients fares poorly, especially after about 2.5 years compared to CABG. And yet we have a population in the ischemia trial which were 40% diabetics, and the large majority of those who got any revascularization got PCI rather than CABG. So, again, the trial is going to teach us a very great deal. I think it's going to require longer-term follow-up and the kind of careful and thoughtful analysis of subgroups that I know Leslie will bring to the endeavor. And I'm particularly happy that she has joined our faculty at Mount Sinai in New York, and indeed in my hospital Morningside, just in the very last few weeks. So we're excited to have such a luminary join our team.
That's excellent. I just want to say that the cat of Leslie was showing the back to all of these cardiac surgeons. I don't know if there is a second meaning there. I don't know if I'm over reading pictures and I'm like just I read too much Freud and Dostoevsky when I was a kid, or what. But if that was a message, I think the message was delivered. Before going back to you, Leslie, I will go with Mario Gaudino and I will give him Mario, give us a little bit of point. Sometimes, it's always difficult. It's extremely difficult, actually. And you know very well and better definitely than me on how challenging it is to run these trials. You have an idea, you have a question, and then you have to realize them, to make them happen. And there's so many caveats, there's so many difficulties, there's so many challenges. And then it's in one way easy finding ourselves in front of a cup of a coffee 1 year later than the trial has been published, finding reasons to undermine or to say, well, the trial was not exactly well conducted. What is the major message that you took from ischemia trial? What do you think about the trial? What is your 2 cents that you're giving us here?
Well, thank you, Gianluca. And, as a trialist and with someone like Mike, that is a mentor for all of us who do clinical trials on the call, I love ischemia. I mean, there is no doubt about that. It's a beautiful trial. It's an incredibly challenging trial. 5,000 patients randomized to intervention or no intervention, and with the need to do CTA with an incredible number of sites. I think just from a trialist perspective, it was an incredible accomplishment. It was a beautiful, smart design. I think what I really liked about the design is that authors could clearly see the issue coming beforehand. And in fact, they had a number of alternative strategies that were already predefined. They changed the primary outcome at some moment due to low enrollment. And but they were able to accomplish one of the best cardiovascular trial in the last 10 years. So I think this is, from a trialist perspective, it's an incredible accomplishment. And all my respect really to Judy Ockman and all the ischemia trial group, Leslie Sripal. I know most of them. How I read the trial? Well, as a surgeon, I like the trial again, because I think ischemia is testing something different than revasc versus medical therapy. I think ischemia, and this is the hypothesis of the trial, is testing what if there is any difference in the initial strategy, not in the strategy overall. Like Mark pointed out, 20% of the patients who were assigned to the invasive group did not have revascularization because they did not meet the criteria for revascularization. And 20% of the patients who were assigned to the initial conservative group, in the end, go to revascularization at some moment during the follow-up because medical therapy was not enough. So I see ischemia as a testing, and that was the aim of the trial. What should be the first approach to a patient that show up to a doctor office with chest pain and has no left main disease, has no low ejection fraction? Shall the patient be sent to the cath lab straight away, or shall we try to optimize medical therapy? Well, the answer seems to be optimizing medical therapy, and I'm totally fine with that as a surgeon. I wouldn't do surgery on someone who is not on medical therapy as optimal as possible. So the ischemia was not designed to compare revascularization versus medical therapy in patients that currently receive revascularization. That's a totally different trial that has not been done, and even less to compare PCI versus CABG. So in terms of what was the primary aim of ischemia, I think ischemia was very successful. And I think it's a very healthy reminder for all of us that medical therapy is the first step of treating coronary artery disease and need to be optimized before getting to the next stage of revascularization. So in this sense, I love ischemia, and thank you for having me this morning.
Gianluca, you're muted.
You're muted, Gianluca.
Thank you. I was trying to, thank you so much. I was trying to optimize the audio and I tried to mute everybody, myself included. So I need a coffee probably. So Leslie, back to you. You have done as part of the ischemia is not only one paper and one journalist, has been a really like a effort in differentiate the different level and different profiles of patients. The most noticeable one for sure is the subgroup of chronic kidney disease, but there's been an incredible effort also in quality of life. So if you can tell us a little bit about the chronic kidney disease and a little bit about the future of ischemia. Are we going to have a 5 or 10 years follow-up of the ischemia? What is the discussion among all of you leaders of this incredible trial? What to expect? What is ahead of us?
Yeah, I think that's a lot of questions, but I think the funding for continued follow-up has been approved and is ongoing across the sites. I think Mario's point is extremely well taken. This was undertaken in 300 plus centers. It is extremely difficult to manage 300 centers in the practice of care and get them to adhere to. I mean, I didn't have gray hair before I started, trials are difficult, and there are these challenging sites from around the world. I think that I think Mike's point is extremely well taken. To me, my take home on the ischemia trial is our challenge with stress ischemia, stress testing. And I think we have ongoing analysis as we speak to look at plaque on that CT. I think that will be highly informative and for us to look at the major precursors that we know for ACS and particularly understand what happened in those non-obstructive lesions that present for downstream acute infarction or unstable angina. Those culprit lesions which are previously 40, 50% stenosis. I think these are major emerging issues that we are tackling as we speak. Stress testing, I think, ongoing is a challenge and problematic. And, I think, those are kind of the major issues with the ischemia trial, which I think we're still tackling with. And the stress testing one, I think, has major implications for how we manage, quote unquote, stable ischemic heart disease. Is it really the subtended myocardium that we focus in on, or is it within the vessel wall that we understand the burden and the severity of plaque features? And I think that will be an ongoing area and point of really where I think the field needs to go. And so those are my comments, I think, in general about what's going on with ischemia right now.
Thank you, Leslie. Mark, back the ball to you. What do you think about these comments? And one of the data that I want to show very quickly is this supplement table number 8 on the paper. And my eyes got to the line here of CABG, internal mammary artery use, 91.9%. So I was wondering, do we have data about what type of surgery patients who received CABG surgery within ischemia got? Other than this one, do we know how many off pump, how much the use of a second arterial conduit has been? Do we have more granularity about it, and what do you think about this comment or this table?
Yeah, thanks, Gianluca. I'll disclose, I'm not one to dissect the procedures that have been used in the CABG group. I think people do what's good for their institution. Generally, research patients are well taken care of, right? The outcomes, there's been outcry around XL, low ITA or bilateral or multi-arterial graft use. I think, institutions who bring someone research protocol, or anybody for that matter, try to do their best. I'm not sure it's really 91.8%. There may have been some miscapture of some ITAs. We see that all the time with research and administrative data. But what I would say, since you're talking about the intervention, I think we made the point about the dilutional effect of ischemia. Now, let's talk a little bit about the intervention. And back to Leslie and Mario's point, it's really early invasive versus early conservative strategy. And there are two things here, what is early and what is exactly driving a team to move someone from conservative to invasive. What did that during the enrollment phase of ischemia, and what would do it now in 2021, now that the results of ischemia are published? Would there be a higher threshold to move someone? Well, ischemia was neutral, right? So we can basically show that they can stay in a conservative group. I worry about that. And I think it's important for surgeons to understand, again, that this is not invalidation of the survival effects and the MACE preventing effects of CABG in multivessel disease. In fact, you could even argue, if you go back to the classic Lancet Selim Youssef 1994 meta-analysis, it's an old paper, I realize. Everyone says, well, medical therapy has improved, but CABG has improved since, and secondary prevention after CABG has improved. At the time, people would get vein grafts, maybe with a mammary, and they would be sent back to nature, and they would not even be on a statin. So both treatment arms have probably improved. It's hard to say how much. But anyways, back to that. At 5 years, those classic indications for CABG, left main, depressed LV function, triple vessel disease. At 5 years, there was no positive p-value of the interaction term. Everyone got a benefit. Essentially, that only showed up at 10 years in that classic Lancet meta-analysis. I know I'm talking about really, really old stuff, and it's time to redo these meta-analyses, and Mario and David and several of us are working on this. But again, in ischemia, are you going to be able to compare the patients who receive CABG? No, you cannot, because you don't have anatomic controls to these patients. You could say, compare them to the medical therapy, they don't do better. They may not, because there was confounding by indication for these patients. They were the patients with the most severe angiographic disease in the intervention, in the invasive group who received CABG. There are no controls that can be anatomically defined in the conservative strategy group. So again, we have to be mindful that the 5-10 years data of ischemia may not even give us the answer. Perhaps they will, but perhaps they will not. I think it's important for our community to know and be aware of these caveats to this very important trial, very smart trial, but this should not be interpreted beyond what it says.
Thank you, Mark. Really, thank you. And I think, the major elements here is just understand what ischemia is. Just go above the line of reading the abstract only or what a newspaper wrote about the trial in the title, but rather understand, read, go deep down into the article, read the editorials that has been accompanying the article itself, and try to get a better understanding of what is the final messages. And in this sense, and I asked to John Pascas and Mike Carabello, and I see that the heart team there is growing and growing.
The heart team is growing. It's waking up after perhaps a little testing of the theory that alcohol will reduce cardiovascular disease last night. But joining us as well as part of our heart team, rounding it out, is we have interventional cardiologist and trialist Dr. David Cohen, who, as many of you know, has a laundry list of New England Journal publications related to, especially to cost effectiveness in cardiovascular therapies. And I don't know if he wants to comment on the cost effectiveness of wine in cardiovascular disease, or perhaps add some wisdom to the overall interpretation of the ischemia trial. I'm interested in his thoughts now that he's just barely awake, and also again Mike Farku's thoughts. But David, please.
I'm mostly here for the view, which you guys can't see, but it's spectacular out John's window. But I think the ischemia trial, at least for has told us mostly what we suspected for a long time. It's confirmed that the main role of coronary revascularization in stable patients, at least outside of certain very specific anatomic subsets, is symptom relief. And that's a very valuable, important, and a goal of many of our patients that we shouldn't underestimate. But we shouldn't go into it thinking we're doing something we're not. I think that's, I'll leave it at that, because I'm only about a third away into my cup of coffee. If other questions come up, I will absolutely chime in.
But back to you, David. You're saying coronary revascularization. I would argue with that. I don't think that applies to CABG. I think if this were the case, the delta, for instance, of mortality that is seen, for instance, with Excel, would mean that interventional therapy is worse than optimal medical therapy. No data have ever suggested that. Many data have suggested that it's no better in chronic ischemic heart disease, but not worse.
No, that's why I said maybe it got lost in the in translation, that outside of specific anatomic subsets. And I think that, we recognize that coronary bypass surgery has a very specific role in complex left main disease, complex coronary disease, and and ischemic cardiomyopathy. Those are, specific areas where we have good trial data showing survival benefits if you watch long enough. And I think that's, that is absolutely important to recognize. Those patients largely were excluded from ischemia, though. Left mains, in particular, patients with symptomatic heart failure as well. So I think most of the patients in whom you would expect the survival benefit of coronary bypass surgery were not in the trial by design. And that's okay.
Yeah, but that being said, we had about 70% of patients with multivessel disease, and we had 42% in the invasive group who had diabetes. So, and only 20% got CABG. So, was CABG underutilized? That's been one of the points that we've made. Obviously, it wasn't any protocol violation. It was left, Leslie, correct me if I'm wrong, to the local heart team to determine that, but probably a flavor of the day, which has been long ongoing, right, to underutilize CABG. I think David Taggart, you've written about this, right, left, and center. So I think, again, we have to understand that CABG has a role with regards to health outcomes, especially in those patients populations that you mentioned, David.
I'd like to hear from Michael Farku. because there are few people who know more about this topic than he. And I feel as if we've not adequately exploited him today.
Well, John, I think it's been a fantastic discussion. I think we've raised the issues. Every trial, although it answers important questions, and I think ischemia has, I think poses and raises newer questions. And the big question for me here is the long term. I think David nailed it, David Taggart. The issue is we need to follow these patients longer, and I'm so relieved that finally NHLBI is sponsoring the long-term follow-up of the study, which for many of our other studies, they have not funded. I would insist, almost beg people to follow for myocardial infarction as well. I don't know, Leslie, if that's the case. The last version I saw was for mortality. But I do think this signal of spontaneous MI reduction in ischemia, with all of the caveats that Mark Ruel points out, it really wasn't testing revascularization as a strategy, but the fact is that there was a reduction in spontaneous MI. We need to follow that in the long term, because I think that's a very interesting finding here that may inform us for the future. And I want to emphasize what David said as well, is that the background medical therapy is important. And it's important that patients are treated optimally medically up front. As Mario points out, we don't want patients subjected to revascularization who have not had in stable patients who have not had an opportunity to have optimization of their medical therapy. So I think there's so many lessons here from the trial. But as I said, I think it's opened up this whole question of how do we test for ischemia? Is testing for ischemia and quantification of ischemia, do we really understand this? Because that's really what's happening on the front lines here. Everyone's getting a stress test. They get it annually. Even in Canada, where I practice, patients are getting stress tested annually with nuclear studies and others. And what are the limitations here? What is this really telling us about ischemia itself? And I think that's the next set of questions that need to be answered.
Go ahead.
Thank you so much.
So just, I mean, we've known literally for generations that the length of time you can go on an exercise test, that if you can achieve 6 minutes without a fall in blood pressure, that irrespective of the subsets of coronary anatomy, that automatically subsets you into a lower risk group. And I think that someone who has stable symptoms is sort of telling you that. And I think that again, the symptomatic state is important. Duration of exercise is as important as the degree of ischemia.
No question.
That's an excellent comment, Dr. Carabello. Dr. Taggart, David, I mean, it is true. CABG is underutilized, but we can be here like the guys crying, and say, "Oh, we are underutilized. We should do better." And it was my older brother who really ate Nutella that day. But on the other side, how can we increase the amount? How can we convince and increase? We have evidence there is benefit. How can we increase the amount of utilization of coronary artery bypass grafting around the world? Because at the end, these data represent, as Mark Ruel was pointing out, the real practice in excellent centers around the world. Probably in other centers, even less, the utilization of CABG surgery. So how can we, as a surgeon, all together convince and promote coronary artery bypass grafting as the best treatment for stable coronary artery disease?
I mean, it's a great question, and we've had a super panel discussion about ischemia. And again, as Mario and many of us have said, it's a great trial. It does provide us with more information, but it doesn't answer, as Mike said, all the relevant questions. I think the main problem in what we do with patients as to what revascularization strategy they get is more dictated often by factors that are not directly relevant to the best evidence bases that we have. So one very obvious example, Mike Farku's Freedom trial shows by a mile that CABG is a clear winner as a revascularization strategy in these patients, and it's accelerating at 8 years. So you have to ask yourself, when there's this kind of evidence in existence, why are a very significant proportion of patients still getting PCI? And to me, the main thing I've seen in different parts of the world is that the ultimate decision for what happens to a patient is dependent on or the absence of a heart team. As an individual doctor treating a patient, it's very easy to convince the patient of anything. We all know that. That's what we do. And it's not always a conscious bias. That's the way we behave. But if you have to sit at a heart team, so if you come to our heart team meeting in Oxford on Tuesday and Thursday mornings, where we review patients and their angiograms, it's very difficult for an individual to convince the rest of the team that we shouldn't offer the best revascularization strategy. Of course, whether a patient wants to accept that strategy is a different issue with its own complexities. But certainly in the UK, if we go to a patient with significant multi-vessel disease, and especially with diabetes or impaired ventricular function, and we just explain that their case has been discussed by a team of experienced doctors whose view is that the best treatment that we can offer them is a bypass operation. In our experience, if patients are given that kind of information, it's incredibly unusual for them to turn around and say, no, I don't want a bypass operation. So I don't think there's really, at this point, as we practice, I don't think there's a lack of evidence from what is a substantial evidence basis. I think the way that evidence is deployed can often be more significant than what is necessarily the best intervention strategy.
That's a excellent comment, Mark. I just try to involve you, Mark. Well, I try to involve you because I know that I can have a shoulder on you about minimal invasive bypass surgery, and I try to get you what the first time I read ischemia as a young surgeon, I was saying, how does that is possible with all of the knowledge that we have about complete revascularization? I've been educated as a young cardiothoracic surgeon to complete the revascularization at the time of CABG as one of the most important elements to guarantee the long-term outcomes of this patient. And after ischemia, after reading ischemia, and maybe after reading the first time in a very superficial way, I was thinking, like, is it really the message here? Is it really that probably once I offer one or two mammary arteries to the best targets of your left coronary system, and I optimize medical therapy to the patients, is really what is the future of coronary artery surgery? And if I can do that without opening the chest, is this where probably we can achieve to have a better or more patients that accept or get into this type of treatments? I tried once to have this discussion with Mario. I already tell you, we were in a restaurant in the Upper East Side. He tried to choke me. I was about to die. He took a knife. It was an Italian restaurant. We have to calm him down. When I started the idea of robotic bypass, double mammary, open chest close, like he just lost on me. So I just involve you. I keep his microphone muted, and please, Mark, help me out in this.
Well, it's a great question. It's a very loaded one, and you know, this is a wonderful panel, not only because of the quality of the participants, but we also are nearly balanced. We have 4 cardiologists, 4 very eminent cardiologists, and 5 surgeons. So we're almost there. But there's no question. Our cardiology colleagues know CABG is so darn invasive, and sorry for the expression, and we have to fix that, because you cannot lack understanding of anybody, any patient or family who don't want to go through this. You know, splitting the breastbone and cutting and tearing the patient in 2 halves is really, it's maybe providing great exposure for the surgeon, but it is so incredibly invasive. And I tell our trainees, if we still do this in 25 years, we take people with chronic ischemic heart disease who are well on Sunday night having dinner with their family, going for an angiogram on Monday morning, and having a sternotomy CABG on Wednesday afternoon because triple vessel disease was discovered. I think the field needs to completely reconsider. We're doing something wrong if we keep on doing that. So we have to move it forward. It would be the topic of an entirely different discussion. And you know, there are many unresolved questions, as you say. You know, the LETA probably, the LED probably provides in most patients 50-60% of the perfusion. Is that where the money is? But then I think, correct me if I'm wrong, you asked Mike. I've asked Mike many times, together in Ottawa and Toronto in front of nice glass of wine. Did you see, was the Lita LED inferential in Freedom trial? Were you able, is it the vein grafts? Is it the complete revascularization? Is it the Lita LED? What did the non-surgery patients, what did the PCI patients die from? And at least, our last conversation, Mike, and I would invite him to comment, was not able to really determine mechanistically what is the positive impact of CABG in those diabetic patients in Freedom, right, in the 1900 patients or so. I think just to finish on what David has said, I think I want to reemphasize the importance of the heart team, and the heart team beyond revascularization experts, because we see heart team as a PCI specialist, a bunch of them with a bunch of surgeons discussing together. Well, I think we need a medical therapy expert, definitely. And not everyone, to me, I often react in not so favorable ways when I see people with left ventricular dysfunction, multivessel disease being offered PCI. Where is the evidence for that? People with chronic ischemic heart disease, minimal symptoms, whose maximal medical therapy has not yet been optimized, being offered PCI. Where's the evidence for that, right? And same thing on the surgery side. Sometimes we may have too easy of a trigger. The point here is not to offer CABG to half of the earth. Like, no surgeon wants to do that. But in the same token, we want people in whom there's a survival benefit, who would benefit from having less major adverse cardiac events, to receive the appropriate therapy. And I think a medical therapy expert on our heart teams is going to be very, very germane. Mike, back to you. What's the benefit of CABG? To answer Gianluca's, is it, is the money on Lita LEDs, the money on doing 6 grafts on everybody? Like, can you give us some insights from Freedom and other trials you've done?
Well, we've tried to evaluate that. The real challenge, and I think it's the success of Freedom, is LIMA to LED was 95% of the patients did get the LIMA to LED even 10 years ago. And so that was following guideline and the guidelines of the surgical working group. But the other big question is completeness of revascularization. And it's embarrassing, but due to some challenges at the core laboratory and looking at residual syntax score and so on, we're just about to finish that analysis now, almost a decade later. And I think we're going to have some very interesting insights from Freedom. So stay tuned. George Dangus is leading this with our folks, our younger cardiology and surgical colleagues in the Freedom trial. And I think that's going to provide us with the final piece of the puzzle. But we certainly have promoted arterial revascularization, looks very promising in Freedom, but the signals are not definitive. And I think that's the next frontier about our multiple arterial grafting as a strategy. And, we've discussed this with Mario and Mark and others, and of course, David. And I think that's the other aspect to this. We just weren't able to really fully evaluate it in Freedom alone.
That's so important. Thank you, Dr. Farku. This is an incredible insight. And I think that was a very, it will be extremely excited to listen to read the paper when it comes out. Dr. Gaudino, just give us, I want to wake you up from your corner, give us some final words. I want to have your words, Dr. Taggart's ones, and then I will close with Leslie. That after she has been surrounded by all of these cardiac surgeons, she has the rights of the last words, her and the cat, hopefully. So Mario, please start.
Yeah, I will be brief. Also in the interest of time, I think we can summarize by saying that ISCHEMIA was a great trial. We really look forward to the longer term result. It's a healthy reminder for all of us of how important is medical therapy, and I think we should all think first as a physician and then as a proceduralist, surgeon or interventionalist. So for me, that ISCHEMIA didn't really change my practice too much. I trained with Attilio Maseri back in the days, and the concept was always to maximize medical therapy and try to treat patients with preventive strategy and medical therapy before getting to intervention, and this is what I've been doing for the last 2 decades.
Dr. Taggart, please.
Thank you, and thank you to you, Gianluca, for organising these morning coffee sessions. They are fantastic, and you've been very modest by not telling everyone here how many hits you're getting on YouTube, etc. But they are being very well received. I think this panel format discussion is brilliant. So again, I would reiterate, I think the ischemia trial is a great trial. I think it's given us more information, but I do think it still is hypothesis generating. It leaves other questions to be answered. But I think the collegiate approach between the cardiologists and cardiac surgeons, and Mark made the absolute crucial point, the non-interventional cardiologists are a very important part of the heart team in Oxford. You know, if we don't have at least 2 non-interventional cardiologists, it's non-quorate. So we take that very seriously. But to me, that's still trying to ensure that our patients, the average, you know, when I take my car to a garage, I'm not a mechanic, and I hope that what I'm being told needs to be done to my car, which seemed to be working perfectly well, does need to be done. But I think the way I'm utterly convinced that the best way for us to serve our patients is to make sure that information provided for them, and certainly in the elective or urgent setting, is reviewed by a heart team, including the non-interventional cardiologist, and that's the advice that should then be delivered to any patient.
Thank you so much, Leslie. I hope that you enjoy this heart team and the way in which we try to host on a Saturday morning here. And there were some cardiologists who joined us a little bit later with their cup of coffee. And this is exactly the spirit. The idea is just try to very nicely chat about the complexity of these trials and learn from each other. Please give us some of your wise words to conclude this talk. And I want to thank you personally for accepting to come and join us. And I want to thank everyone here around. Leslie, please, your words.
Thank you so much for inviting me. It's been great fun. It's a great way to start my weekend. Nice long weekend, Monday off, right? So I think that, first of all, I think that there's a couple take-home messages. With every trial, the devil's in the details, and we need more information about completeness of revascularization. I know we saw Greg Stone did that presentation, but we haven't really seen the details. You know, I think that take-home messages for the non-interventional cardiologist has been, you know, somebody with moderate to severe ischemia. Oh my God, we gotta rush to take care of these folks. Well, I think one of the facts we've learned is these patients are pretty darn stable, right? And a rush to do anything was not manifest in ischemia. And, you know, perhaps that's another take-home message. And the role of ischemia testing, I think, is something that we really, truly have to explore in terms of future trials. And, you know, in particular, a comparison to overall plaque burden and plaque features. You know, is that the future of where we're going in terms of both optimal medical therapy as well as interventional strategies?
That's excellent. I want to say great discussion to everybody. Thank you so much for joining all of us. Thank you, Dr. Farku, to come and join as well. We really, really appreciate your input and your presence. Dr. Carabello, was amazing to see you side by side to doing a morning session, heart team meeting in front of some Tylenol, water, and probably the rest of the wine of last night. And the rest, really thank you, everyone. Looking forward to another of this session. Again, the aim is try to learn and learn together and learn better by sharing all of our knowledge. Looking forward for our next International Coronary Congress, and I want to leave you with the final reminder of the International Coronary Congress meeting that will be held in New York City in December. And I think that this is the way in which we want to conclude this live talk today. Thank you again, and have a great long weekend. Bye.
Grazie, Gianluca.
Bye.
Thank you, everybody.
Bye-bye.
We'll see you all in New York in December.